बेटे चार्जिंग हेलो Shubham, Dr. Laskar is in.
I can't see him, sir. If he's not, is he not with his name? Because I can't see him. Can you ask him? Yeah. कौन सा उनका ID है? I can't see him.
He is just logging in.
No problem, sir. No problem. Sir, so last time, just like last time, we have another five MCQs that we'll just have before the start. Again, that we have had. So just to start the ball rolling, and we'll discuss all of them as we come across them.
Sure.
Okay.
You will introduce him, right?
Yeah. I'll do that.
Dr. Laskar is Deputy Director, Academics.
Yes, I know.
And
you can introduce him. I think that will be a fair call. Sir,
no, that's not a problem.
Hi, Ashish.
Hi, sir. Welcome.
Hi, sir.
Hi, how are you?
Sir. I am well, sir. How are you, sir?
Excellent.
Thank you for doing this for us, sir. I'll just make you a co-host so that you can control your audio and video, sir.
Okay.
Okay. Great. Sir, the format is such that we usually take a topic which we feel is of relevance to most of our DNB and postgraduates and MCH DM students who we started this as for our institute, but it has now snowballed into something bigger and we are happy to run it. And we take questions which have come in the previous years, and this is one of those questions. And the aim is to generate answers from faculty themselves, which they would want to have it as they would check it in a paper, in a written format, or whatever pertinent things that you think the student should know from the exam point of view. So we that is what we try to do. Just to make it interesting, we have a short quiz beforehand. It's 5 MCQs that we ask related to the topic, and we give answers at the end of the quiz. And we are very sure that you'll cover most of them during your discourse. So it helps us. Dr. Gulia has been very kind to us in curating the content for bone and soft tissue, and he spoke to you and arranged this for us. And always,
I'm glad to be a part of it.
Great, sir. Great, sir.
Yeah.
So we start at 8:30. It's okay. It's 8:32. Sorry, we'll just.
Yeah, it's 8:30. Yes, yes.
Yeah. I'm sorry. All right. So good evening, and it's Wednesday, 8:30 p.m. It's the Cancer Academy time, and we are very lucky that we are being able to continue our series on bone and soft tissue tumors. And Dr. Ashish Gulia, who's a professor and convener for bone and soft tissue services at Tata Memorial, has been very kind to us, and he has almost taken the responsibility on himself to curate content for these series of lectures, and going on from the last set of lectures where we heard from Dr. Gulia talking about management of bone tumors. We are now moving on to soft tissue sarcomas, and we have today with us none other than Dr. Siddhartha Laskar, who's the professor in the Department of Radiotherapy at Tata Memorial Hospital and a very senior member of the bone and soft tissue DMG. He's also the Deputy Director of Academics at Tata Memorial Hospital, and he is one of those mentors who has at least 2 or 3 MD students with him. Sir will correct me the right number, and he's the perfect person to speak on this, and I'm sure he'll be able to answer most of your questions. Just like always, we have a small quiz which has been prepared for our attendees by Dr. Prekshi. Dr. Prekshi is a senior consultant in radiotherapy at Max Hospital, Vaishali in Patparganj, and our aim is always to generate interest. These questions are something which you would normally, or most of you would know answers to, or would actually hear about it during this discourse, and we'll discuss the answers at the end of it. May I now request Dr. Prekshi to please switch on her camera and mic so that she could, read out those questions. I'm sure she'll do a better job than me because all of these are radiotherapy oriented questions. The format of the quiz is, all those who have attended it already know that you have to submit your answers on WhatsApp at this number 9953 621242, and you have to send this answers in a single message, as a single WhatsApp. Write your name, your institute name, and the answer as whatever is the right sequence of answers. And Dr. Ashish Gulia has promised us to arrange a prize next time. So we don't have a prize yet, but we are very sure that Dr. Gulia will do something for us. So Dr. Prekshi, over to you.
Yeah, thank you, Dr. Shubham. Good evening, everyone. So,
Prekshi, can I interrupt for a?
I knew this was coming. Yes.
No.
Sir.
I actually want to encourage all the students that, as I promised last time, that the winner of the sarcoma session quiz, I will host them in the next IMSOS meeting, and this is initiative which I am taking from my own side, that one person from surgical oncology side, one person from medical oncology side, and one person from radiation oncology side, I will sponsor their attendance in the upcoming IMSOS meeting. So please be very attentive and answer very carefully. Thank you.
So the stakes have been risen by Dr. Gulia, and Dr. Prekshi, you can read out those questions, please.
Yeah, sure. Thank you, Dr. Shubham. Good evening, everyone. So to begin with the quiz, the first question is, which of the following is the most radio-responsive soft tissue sarcoma? First option is pleomorphic sarcoma. Second is myxoid liposarcoma. Third is clear cell sarcoma. And fourth is leiomyosarcoma. Here you need to know, and you must be knowing, that there is a difference between radio-responsive and radio-sensitive tumors. So, okay. Next question, please. The second question is, all of the following statements are true about radiation for STS except dose for pre-operative radiation therapy in soft tissue sarcoma is 50 gray. In post-operative settings, the dose is 50 gray followed by phase 2, a boost dose, which is up to 63 to 66 gray. Dose for HDR boost is 12 to 20 gray, and for LDR, it is 12 to 20 gray. Our third question is, following are the advantages of pre-operative radiation over post-operative radiation in soft tissue sarcoma, except. So you have to choose the false statement. The first option is reduce seedling during surgical manipulation of the tumor. Thickening of the tumor capsule may lead to easy resection. The third option is that pre-operative RT has lesser wound complications. And the fourth one is smaller RT field size. The RT field size are smaller in pre-operative as compared to post-operative settings. Next, please. Yeah. So, which is the correct definitive radiation dose for desmoid tumors? First option is 30 to 40 gray. Second is 50 to 56 gray. Third is 60 to 66 gray. And 4 is 70 gray. Definitive doses for desmoid tumors. Question number 5 is, following is not true for IORT, intraoperative radiation therapy, in retroperitoneal soft tissue sarcoma. Again, you have to choose the incorrect option. So the first option is dose escalation is possible with IORT while limiting the doses to surrounding normal structures with the help of shielding or with the help of retractors. Second option is the typical dose used in intraoperative radiation therapy is 10 to 15 gray. Third is electron intraoperative radiotherapy has lower rates of peripheral neuropathy as compared to brachytherapy, HDR, IORT. Fourth option is commonly IORT is used where there is difficulty in obtaining wide surgical margins. So you have to write your name, your institute name, and the sequence and send it to the above WhatsApp number. And at the end of the talk, we will again be coming with the quiz answers.
All right. Thank you so much, Dr. Prekshi. And with this, I will hand over the virtual platform to Dr. Laskar sir to make his discourse. Just for knowledge of everybody, and especially the speakers and the moderators, that this is live on YouTube as well and is being recorded and will be available on our archive, which is the YouTube channel Cancer Academy, for future references also. Sir, my mic and camera and most of other people would be muted. We'll be there for any technical support, and we prefer to take questions at the end of it until unless you want to interrupt and ask some questions in between. We usually read out the questions at the end, and we try to have a very interactive session, and I'm sure Dr. Gulia will make it more interesting. Okay, thank you.
So thank you very much. Good evening to all of you. I hope I'm audible and my screen is visible.
Yes, sir. It is. You're audible, visible. Yes,
sir.
Great. So I expected that most of the audience would be a mix of radiation oncologists, surgeons, medical oncologists. So instead of only talking about radiation, I mixed in a little bit of questions that we face in our everyday practice in the clinics, and I hope it will be useful. I will also slightly dwell deeper into the radiotherapeutic aspects if in the discussions later. So I'll broadly look into the principles and the evolving evidence that today's students and today's clinicians should be aware of regarding the use of radiation therapy in soft tissue sarcomas. Now, when you look at soft tissue sarcomas, now it's a whole gamut of histological subtypes that we are talking about. And if you look at the broad classification by the WHO, you would broadly classify them into the non-round cell types and the round cell types from the therapeutic point of view. From the origin point of view, you can see the various histological subtypes that we look at. And one of the subtypes is actually, a couple of the subtypes are actually there, which was asked in your quiz. Now, coming to the locations of the body where you could have soft tissue sarcomas, you can see from this cartoon, majority of them would be involving the extremities, and a large proportion of them involve the retroperitoneum and the trunk. although there is no restriction to the sites that could be involved by soft tissue sarcomas. So, but today I will only deal with the non-round cell soft tissue sarcomas, because if you go to the round cells, it will be another large topic to be discussed. Now, all of us know that the standard treatment for soft tissue sarcomas has been surgery. And this is because the non-round cell soft tissue sarcomas have generally been known to be radio-resistant and chemo-resistant. And thus, the standard treatment has been surgery. If you look at this table, it basically shows you the rates of disease recurrence associated with amputation versus wide local excision versus marginal excision. And you would notice that if you have an amputation, obviously the local recurrence rates would be very low. And if you do a limb preserving surgery, there are chances that the local recurrences will be slightly higher, as you see here, in the range of 25 to 30%. And if you do a marginal resection, which is a suboptimal surgery, then the recurrence rates are extremely high. So where does radiation come into the picture? So this is what Will Enneking, who's a surgical oncologist that all of us know, mentioned about the role of radiation therapy in soft tissue sarcomas. He said the value of adjuvant radiation therapy is in extending the margin of limb salvage surgery that otherwise has a high risk of recurrence. So broadly what he says is that with surgery alone, it would be very difficult to do organ and function preserving surgery, which is the standard of treatment nowadays. And that is where radiation comes in, and radiation helps in allowing the oncologist to do organ and function preserving procedure. So being people of science, we need to talk evidence. And so the question is, how do you know that radiation actually helps in organ and function preservation? This is the first study, a randomized trial comparing amputation versus limb sparing surgery. And what was seen is that in patients with soft tissue sarcoma, where you did limb sparing surgery along with radiation therapy, and both groups receiving chemotherapy, the local recurrence rates, obviously in the amputation arm, was 0, but they were significantly lessened when radiation therapy was added. The other important landmark that we use for defining efficacy of a particular treatment is overall survival. And what was seen in this study is that there was no difference in overall survival between the group that underwent amputation versus the group who underwent a limb sparing surgery and radiation therapy. And this was primarily the basis for the NIH consensus development meeting, where it was defined that combined surgery and radiation therapy would be the standard of care for localized extremities soft tissue sarcomas. And this was published in Cancer Treatments in 1985. So this was the first big evidence that came towards organ and function preservation. Now, so this is another study that came on limb sparing surgery alone using wide local excision versus limb sparing surgery with additional radiation therapy. And this was a randomized controlled trial again. And what was seen is that after a long follow-up of 115 months, which is long enough to define whether a treatment is effective or not, what was visible is that limb sparing surgery and radiation therapy resulted in better outcomes compared to limb sparing surgery alone. That is wide local excision. So another additional information that came from this study was that in patients with low-grade soft tissue sarcomas, although radiation was useful, the efficacy of brachytherapy was less relatively compared to its efficacy in high-grade soft tissue sarcomas. So this was the other information that we got, is that if you add radiation therapy after wide local excision, the local controls were better than the patients who had wide local excision alone. Now, we all know that. But then we have come a long, long way. And this is a more recent information that we are looking at here. And broadly, why did I put this slide up? I put this slide up because there has been a lot of debate. We understood the role of radiation therapy, learned the role of radiation therapy. We realized that addition of radiation therapy improves outcome in terms of improvement in local control. But there has been a debate of late of whether we can actually avoid using radiation therapy in a particular group of patients. Now, the evidence that is available is that for some patients with small tumors, which are less than 5 centimeters, which are low grade and which are superficial and completely resected, this is a very favorable group of patients that can be observed without any adjuvant therapy. But the question is, can we avoid radiation therapy in patients with high-grade soft tissue sarcoma with similar characteristics? Now, so if you go back to these two large databases, these are not clinical databases. These are, more of an epidemiology databases from the NCDB and the SEER database. The NCDB database had almost 7,000 patients, and the SEER database had almost 3,000 patients. So these are relatively large databases over a long duration of time. And what they looked at is, they looked at whether after organ and function preserving surgery or amputation, when you compare with the outcomes of patients who had surgery and radiation therapy, either in the preoperative form or the postoperative form, was there a difference in local control and was there a difference in overall survival? So I put this data on overall survival. As you can see these curves, it's quite surprising that patients who actually had amputation and those patients who actually had limb sparing surgery alone had inferior overall survivals compared to the patients who had limb sparing surgery and radiation therapy. So this clearly shows that there is definitely benefit, not only in terms of improving local control, but there is also improvement in the overall survival with the addition of radiation therapy. And that is why now the current NCCN guidelines and all the other guidelines would recommend that for intermediate and high-grade sarcomas undergoing a wide local excision or organ and function preserving surgeries, adjuvant radiation therapy is a standard of care as of now. Although we may be able to identify a group of patients within the high-grade sarcomas with favorable features where you may be able to avoid radiation, but we still do not have the answer to that question. So since a lot of you are radiation oncologists, and this is also of interest to our surgical colleagues. So which is better? I mean, there has been a lot of discussions regarding the role of preoperative radiation therapy vis-a-vis postoperative radiation therapy. Now, theoretically speaking, these are the advantages and disadvantages. So because in preoperative radiation therapy, we are handling a field that is fresh and non-interfered, it is assumed that the field size could be actually smaller. And with smaller field sizes, obviously, you would expect less toxicities. The other thing is, since this has not been interfered and there is no fibrosis, theoretically speaking, there is better blood supply, better oxygenation, and probably lesser doses of radiation would be required to sterilize the microscopic disease that may be there. The other advantage of preoperative is that it prevents the delay between, if we are assuming that surgery is the mainstay of treatment, you're actually delaying the main treatment that should be done for the patient. And of course, it probably limits the dissemination of viable tumors into the circulation, which we know is a major problem with soft tissue sarcoma, the pulmonary metastasis that may happen. And the last advantage is that it probably improves resectability, But we will have a discussion on that later on. Maybe Ashish is there, Shubham is there, we can discuss that. But I don't know whether it improves resectability, but probably it reduces the chances of having a positive surgical margin. Post-operative radiotherapy, again, has its own advantages. You can tailor the shape based on the kind of tumor it is. You have a better idea about the surgical, about the tumor, the shape, the extent of disease, and the histological subtype. And it probably also eliminates radiation therapy for the favorable group of patients that I mentioned, the ones with low-grade superficial tumors. Now, do we have any evidence to say that pre-op radiation therapy is better than post-op radiation therapy, or the other way around? So this was a randomized trial, and this is actually the only randomized controlled trial addressing pre-operative radiation therapy versus post-operative radiation therapy. This is the SR2 trial from Canada, Brian O'Sullivan's group, published in Lancet in 2002. Everyone quotes this trial: extremity soft tissue sarcomas, pre-op RT plus limb sparing surgery versus limb sparing surgery followed by post-op external RT. Equal number of patients. In the pre-op group, the dose was slightly lesser compared to the post-op group. I don't know what was the clear logic behind it, but it was less. And the primary endpoint was not survival, nor was it local control. They kept the primary endpoint as a complication in 120 days. And this is probably because if you kept survival as an endpoint, you would never complete this trial ever. So with a follow-up of 3.3 years, the broad difference between these two, the pre-op and the post-op group, was that in the wound complications, the wound complications were almost double in the patients who had pre-operative radiation therapy compared to the ones who had post-op radiation therapy. Now, this first publication in 2002 was the early results. We also had the long-term results. And broadly, the problem with preoperative radiation therapy was complications. But what was better in preoperative radiation therapy was the survival. So there was a statistically significant improvement in overall survival in the group of patients who received preoperative radiation therapy. So this is what we got to know from the Brian O'Sullivan study, SR2. Now, because we had such high complication rates associated with preoperative radiation therapy, so the authors started wondering what could be done to reduce the complications in these patients. So what they did was they preempted the surgical site or the surgical scar even before we started radiation therapy preoperatively. They marked out the area, and during radiation therapy, in a planned manner, the dose to the possible site of scar was reduced to lesser than the full dose that you would deliver. Idea being that the area that you would have a scar would be fresh and would not have had the full dose of treatment, radiation therapy, and the complications would be reduced. So when they looked at the outcomes of this study, yes, they were successful in reducing the complication rate significantly. The skin complications rate reduced, and also there was a reduction in the joint stiffness, there was edema and subcutaneous fibrosis. So compared to the SR2 trial of Brian O'Sullivan, the second study where they planned to avoid or reduce the dose to the scar site did result in improvement. So the message is that yes, if you're planning for preoperative radiation therapy, there obviously is a good chance of complications, but you could possibly reduce the chances of complications by using these techniques like IMRT and reducing doses to the skin and subcutaneous tissue if possible. So instead of just sticking to just one group reporting on their outcomes, I just thought let us see if others have also reported on the complications of preoperative versus postoperative radiation therapy. So broadly, with all kinds of fractionation, 2 gray per fraction, 25 fractions, 1.8 gray per fraction, 28 fractions, all delivering a dose of around 50 gray to 55 gray. The complication rates were all hovering around somewhere around 30%. So that's quite a lot of complications, wound complications that would happen across all the studies that have been published and that looked at the complications of preoperative radiation. Generally, if you really look at it, post-operative radiation therapy with proper surgery and radiation, the wound complication rate would generally be almost half of. So that needs to be remembered when you're deciding between preoperative versus post-operative radiation therapy. So for the radiation oncologist, it is pretty simple. We all know what is gross tumor, what is clinical target volume, and planning target volume. So this is how we draw our target volumes. And whenever we are treating a particular area with radiation, we always keep in mind what the possible sites of toxicities could be. And in the extremities and other parts of the body, one of the common sites in soft tissue sarcomas that could be our organ at risk is the bone. And this is an example of bone being spared, or we have just contoured, and how we can spare the bone from receiving high doses of radiation. For the non-radiation oncologist, if this is a tumor bed, and if you just treat through and through like that, a significant dose of radiation would go to the bone. And if you're doing a more refined form of radiation, like IMRT, you would possibly be able to reduce the dose to the critical structures like bone or the normal tissues, the subcutaneous tissue. Now, question is, first of all, can you really reduce the dose to these structures by using conformal techniques or IMRT? The answer is yes. By using intensity modulated radiation therapy or conformal techniques, you can significantly reduce dose to various structures like the bone, the soft tissue, the skin, and so on. This is just an example, but this can really be generalized. With the use of conformal techniques, you can reduce the dose. But the question one would ask is, does reduction in dose really impact on these complications? And do we have evidence? And if we have evidence, what does the evidence say regarding fractures and soft tissue complications? I'm just using fracture as a complication here after the treatment of soft tissue sarcomas. Now, normally for post-operative doses, one would use a dose of 60 to 66 gray. For patients with negative surgical margins after a wide local excision, you would do 60 gray in 30 fractions with a field reduction at 50 gray. And for the patients with microscopic positive disease, you would do 66 gray. Now, with these kind of doses of radiation, from this study, you can see that the risk of fracture is about 5 to 6%. But this depends on various factors. And this is shown a little bit in this other study that I've shown lower down here, which showed that reduction of the volume of bone radiated to a higher dose could actually reduce the dose or the chances of a pathological, of a radiation-induced fracture of the bone. So it does make sense trying to reduce the dose to the bone and the soft tissue. As you can see in the SR2 trial and the Brian O'Sullivan second IMRT study, it can significantly reduce the wound complications with sparing of skin and subcutaneous tissue. And from these studies, you can see that by reduction of dose to the bone and the volume of bone receiving the high dose, you can reduce the bone fractures in the future. So, so this is another study comparing local recurrences. So you can reduce the complications, but does it have an impact of using IMRT and more fancy techniques compared to conventional radiation in reducing the local recurrences? So this is not a very large study, but has a long enough follow-up. It shows that with IMRT, the local recurrence rates actually in this study seem to be lesser compared to conventional radiation therapy. I fail to understand how with IMRT one would be able to improve local controls in these patients, because I would expect that with conventional radiation, the chances of having a geographic miss would be lesser compared to IMRT. And in this study, the doses of radiation were also not escalated. So I don't see any other biological reason also why the local recurrences would be lesser in the group receiving IMRT. But this was a result published from MSKCC. Now, for the radiation oncologist and also for the surgeons, why do we have these volumes called the gross tumor volume? Obviously, is the volume that you can clinically palpate and radiologically see. The CTV, or the clinical target volume, is the volume of tissue that probably has microscopic disease which needs to be covered in the radiation field. And the PTV, or the planning target volume, takes into account the organ motion and other movements that needs to be taken care. Now, one needs to know why that margin of 5 centimeter or 4 centimeter or 2 centimeter beyond the tumor. So that applies also to surgery, by the way. When you do a wide local excision, why do you do a wide local excision to a margin of 1.5 centimeters or 2 centimeters beyond the gross tumor? Is there a biological basis to it? So this was an elegant study where they tried to correlate the radiological findings with the pathological findings to see how much beyond the tumor or the visible tumor did the normal tissue have microscopic disease. And what was seen that almost 67% of the patients did have microscopic disease or satellite disease beyond the gross tumor that was visible. And that's quite a large number. So we know that there is disease even if you have a negative surgical margin. And the other information that we got from this study is that most of the tumors or most of the microscopic extension was actually less than 1 centimeter beyond. So although we had a margin of 3 centimeter, 4 centimeter, but most of them would be within 1 centimeter. Almost 40% would be within 1 centimeter of the gross tumor. So based on that, we have some information on what were the outcomes based on what margin of CTV did you do. So from this very old study, it was reported by the authors that if you had a margin of less than 5 centimeter in your phase 1, that means the 50 gray volume was less than 5 centimeters, then the local controls were almost 30%. That was not acceptable. And that was the basis of why in soft tissue sarcomas with high grade tumors after wide local excision, the phase 1 would be tumor plus 4 to 5 centimeter margins. I will come to the more recent data on what the margins should be, but this was the basis. And what was also seen from this study is that a margin of more than 10 centimeter did not really improve the outcomes any further. So 5 centimeter was taken as a standard margin for a phase 1, and it was a significant statistic. People looked at, was it really necessary to have a margin of 5 centimeters? So this is the Vortex trial being run in the UK. The first phase of the trial is actually over, the Vortex 1. They're currently running Vortex 2. So what they broadly did is, this was a randomized controlled trial where patients were either given radiotherapy with CTV1 or the first phase with a 5 centimeter margin, and a phase 2 with a 2 centimeter margin. Whereas in the experimental arm, the margin was not 5 centimeter, it was only 2 centimeters. And the doses were similar. In phase 1, in the standard, it was 50 gray followed by a 16 gray boost, whereas in the experimental arm, it was 66 gray. The outcomes were more or less same. It was 67 in the experimental arm and 72. It was not really statistically significant difference between the two arms. So they concluded that we cannot really say whether 2 centimeters actually inferior. They are more or less similar, and now they're looking at this question in their next subsequent study, the Vortex 2. So we still await the answers from them, but I personally believe that probably 5 centimeter of margin is not really required. Now, another important thing comes for both surgeons, radiation oncologists, and medical oncologists. Many a times we have patients who are operated and take a long time to come to you for opinions regarding radiation therapy or other adjuvant therapy. Now, this was a retrospective study of a large cohort of patients from the French group, looking at the significance of time interval between surgery and starting of radiation therapy. So what was seen is that in this group, at least, with a large follow-up of 235 months, the 10-year local regional relapse-free survival was 57%. It was 10 years, and the overall survival is 64%. So this is pretty much standard. And there was no real difference between less than 40 days, 40 to 80 days, 80 to 110 days, and more than 110 days in the local relapse-free survival and the overall survival. So I'm not trying to say that, wait for 3 months before you start radiation therapy, but yes, if for some reason you are unable to start radiation therapy immediately after the wound has healed, you can possibly wait for about 1.5, 2 months without a significant detrimental effect on the outcomes. Now, the other question that comes in is, how safe is doing radiation therapy after reconstructive surgeries? Now, there's a lot of reconstructive surgeries that happen in the process of organ and function preservation. And at times we are worried whether addition of adjuvant radiation therapy would actually hamper the outcomes in terms of wound complications. And from this study, from the Netherlands and Canada, it was a relatively large study of 800 patients. What was seen is that in patients who had flaps, free flaps or pedicle flaps. Now, mind you, these were not skin flaps that we are talking about. So if you had skin of free flaps or pedicle flap with good vascularity, then there was no increase in the post-op complications or post-op radiation therapy complications in these patients who had plastic reconstruction. So that's again an important message that patients who had plastic reconstruction, if they have a free or a pedicle flap with good vascularity maintained and the wound is healed, the complications are not significantly higher than patients with primary closure. Now, the other important thing that people are looking at now is that we all know that if you reduce the volume of radiation and if you reduce the dose of radiation, the complications would expected to be less. So, but then we don't have randomized data to tell us what the right dose of radiation is. So currently for R0 resection for a high-grade soft tissue sarcoma, we would recommend 60 gray. For the R1 resection, that is microscopic disease, we would do 66 gray. And when we are doing definitive radiation therapy or gross residual, we would escalate the dose, the gross residual mass to 70 gray in conventional fractionation. So this is some data that came from a retrospective study regarding the impact of reducing the doses. And without going into much detail, broadly what we generally see is that for patients with negative margins, possibly there is a way that we can reduce the doses to less than 50 gray also without compromising on the overall survival. This is not mature data. This is not a huge randomized data, but this seems to be giving us some indicator as to the amount of dose of radiation that is optimal. So the other thing that we do now that we are doing preoperative radiation therapy, now many a times we have faced this problem in our clinic that a patient receives pre-op radiation therapy and then undergoes surgery. And at surgery, your margin comes positive. So the question now is it worth doing additional radiation therapy boost for these patients who have additional margin positive after preoperative radiation therapy, and what do we do about them? So it is very important that you do a proper evaluation, and you better be sure if you're doing your preoperative radiation therapy that you would be able to get the disease out completely. But just in case you are not able to do that, number one, you need to evaluate in the operating room whether you have a negative margin. By that, you can actually do brachytherapy to escalate the dose to that area. Or you could probably boost that area of positive margins to a higher dose. The question is, does it really impact local control and overall survival? So in this study, which was published quite some time back, they showed that addition of a boost did not really have a significant impact on the local control. So the no boost, as you can see here, had the best local control, and the ones who had brachy IORT or post-op radiation, external radiation therapy had inferior local controls. But what was not expected was that there seemed to be an improvement in survival, disease-free survival in the patients who actually had boost radiation therapy. So this is controversial whether a post-op boost in patients with positive surgical margins would actually help in improving outcomes. So we still have to see. But I would say in our institute, what we would do is we would not really be very keen on doing external radiation therapy, but just in case we have a possibility of having a positive margin, we would consider or at least evaluate for intraoperative or interstitial brachytherapy perioperative. So that now comes to the next question, whether brachytherapy is useful in soft tissue sarcomas. Now, this is again a randomized trial at that point in time, published in 1996. This was one of the earlier randomized trial addressing the efficacy of interstitial brachytherapy in soft tissue sarcoma to improve local controls. And as you can see here, after a long follow-up, median follow-up of 76 months, the local controls in the surgery alone arm was 69%, and those that in the arm that received brachy was almost 10-15% higher, and this was statistically significant. Again, the same thing about the improvement in the magnitude of improvement in the low-grade sarcomas was not as high as in the high-grade sarcomas. But that doesn't mean that brachytherapy doesn't work in low-grade soft tissue sarcomas. And with the change in concept, at that point in time, we were using low dose rate continuous brachytherapy, whereas now we are using high dose rate fractionated. And the biology of these two are different, and the impact of high dose rate and low dose rate is different in these low-grade soft tissue sarcomas, which has got something to do with the cell cycle time. Now, we have brachytherapy, and we also have the fancy techniques like IMRT now. And do we have a randomized controlled trial to compare the outcomes of brachytherapy with IMRT? Now, we don't have a randomized controlled trial, but we have this study, a comparative study from MSKCC, and my friend Khalid Elektiar, who is a very big enthusiast of brachytherapy, has actually started doing IMRT for soft tissue sarcomas. And he compared the outcomes. And broadly, what he showed was that the outcomes with IMRT was about 10% superior compared to what you did with brachy. But the downside was that the complications with IMRT was slightly more compared to interstitial brachytherapy. Now, when we look at our data and compare our data of brachytherapy with the Khalid Elektiar's data, we see that they had a complication rate of 11% in brachytherapy, but our complication rate is almost 5%. So our complications with brachy is significantly lower. And the local controls with HDR brachytherapy, the local controls is 96%, and this compares very well with the IMRT data of MSKCC. So in our institution, even now, we generally would prefer to do post-op radiation therapy, and wherever feasible, we would evaluate for interstitial brachytherapy as a radical treatment. We do not back them up with external radiation therapy unless we feel that we will not be able to treat the entire tumor bed adequately with brachytherapy. So we have used the same principles of interstitial brachytherapy both in our adult patients and in the pediatric age group. I feel personally that in the pediatric age group, both for the round cell and the non-round cell soft tissue sarcomas, brachytherapy is an extremely useful tool. That is because in pediatrics, we are even more concerned about the toxicities and the effect of radiation therapy or external radiation therapy on the growth cartilage, the muscles, and the bones. And as you can see here, our long-term outcomes data shows that the local controls in the range of 83% to 85%, survivals of 73%. Of course, the smaller tumor and the better prognostic groups were doing even better, close to 90%. And the complication rates were extremely low in the range of 5 to 6%. So complications of 5 to 6% generally with brachytherapy, and local control rates both in the adult and pediatric age group in the range of 85 to 90%. It is comparable and slightly better in terms of toxicity compared to IMRT. Now, coming towards the end, what is the role of radiotherapy in patients with metastatic disease, with pulmonary metastasis from soft tissue sarcomas? Now, so this was a recent study that was published in Clinical Oncology, where SBRT was used for a large number of patients. And as you can see, that the outcomes compared with surgery, SBRT fared pretty good. So SBRT seems to be a good modality for treating pulmonary metastasis, and that would result in outcomes similar to surgical excision. So to just summarize, radiation therapy, as you have seen, it plays a significant role in the multimodality management of soft tissue sarcomas, both of the extremities and other sites. It has a significant role in the policy of organ and function preservation in soft tissue sarcomas. Both external beam radiation therapy and brachytherapy, either done alone or in combination, seems to be improving outcomes. The complications associated with the normal tissue complications with brachytherapy seems to be slightly lesser compared to external beam radiation therapy. Brachy and external RT both seem to be effective in improving outcomes, both in low and intermediate grade. Although there is a lot of debate on why radiation should not be used in low-grade soft tissue sarcomas. But if you really look at the evidence that is available, there is clear evidence in a randomized trial, which is a small-sized randomized trial from Canada. There is improvement in local controls, even in patients with low-grade soft tissue sarcomas that have been excised. So that's the reason I showed the third slide, where they looked at long-term data of the NCD and the SEER data to show that the outcomes are better in terms of local control and survival in soft tissue sarcomas, both low and high grade. So, and there is data to show that radiotherapy improves, has an impact on the overall survival too. And that again comes from that data. And there is more data from single institutional studies to show that improvement in local controls with radiation does translate in an improvement in overall survival, which is not always statistically significant. The techniques and the complications I talked about. And of course, radiation therapy also seems to be useful in patients with metastatic disease, with pulmonary metastasis. If there are limited metastases, that can be treated with techniques like stereotactic body radiation therapy. So I think that is all that I have, and I'll be happy to have some discussions and answer some questions if you have any. So I'll stop sharing my screen so that we can discuss.
Thank you, Dr. Laskar, for a very elaborated talk on the existing and the upcoming role of radiotherapy in soft tissue sarcomas. And thanks for elaborating a lot on brachytherapy, and that's where we have a lot of questions coming up. So maybe I've gone through the questions, and I will just moderate it. And so one of the first questions which we had is, can you speak a bit about how um, a bit about contouring CTV in post-operative retroperitoneal sarcomas, and where often the R0 resection, the tumor bed is filled with normal bowel. So how do you plan these cases, specifically retroperitoneal sarcomas, where the planning is extremely difficult because the scattering of radiation may cause a lot of toxicities? So how do you plan these cases?
So thank you, Ashish. So I did not touch upon retroperitoneal sarcomas. It was because it was completely a separate topic. But you are right that it is a challenging task to treat retroperitoneal sarcomas. But I would not say that contouring of retroperitoneal sarcoma is really difficult. I would say the task for the surgeon is much more difficult in the retroperitoneal region than in the extremities. That is because of the critical structures that are located around, the difficulty in getting margins. But we all get worried looking at the preoperative scans, which shows a huge mass bulging into the abdominal cavity, coming close to the kidneys and the vessels and the spinal cord at times. So that is a bit scary when you see. But what is important is that the surgeon actually excises it. And your challenge as a radiation oncologist, when you're defining the CTV, that means the area that possibly harbors microscopic disease, is to be able to identify the pedicle. If you are able to identify the pedicle or the base where the surgeon excises it, it becomes easy. And the volume actually reduces, the volume of radiation actually reduces to almost 1/5 of what you would see in the, you don't have to treat the initial pre-treatment volume that is going into the abdominal cavity. You just treat the tumor bed. So your challenge as a radiation oncologist would be to identify the tumor bed in consultation with the surgeon, and also after having a look at the pre-treatment CT scans. And then it becomes easy.
Sure, sure.
So how useful is the clip placement that we do at the tumor bed? I mean, how helpful you feel is in how many clips should we place ideally? You know, we just put it at the uppermost and the lowermost extent, but does it actually translate into help for you?
Frankly speaking, how helpful it is going to be all depends on how friendly your surgeon is, because it all depends. It's not, sometimes, many a times, our radiation oncologists get fooled by the vessel clips. As you are dissecting the tumor, you keep putting clips to, stop bleeding as you're dissecting out. So sometimes, or actually many a times, you can get fooled by looking at these clips and thinking that this is the tumor bed, which is not. So if you really want to go by the clips, you need to tell your surgical colleague that, look, when you are excising, please see that you put in the clips at the edge of the tumor where you are excising. Which, unless you tell them, they would not be interested in doing that. They would excise and go out, and then you can come into the field and do whatever you want. So yes, it can be useful if you've already told them. So it's a mix of both.
Shubham, I'll just add here. So it's very important again to have a collaborative decision before the surgery, and we need to understand each other's language. And obviously, many times we discuss the scan pre-operatively and then post-operatively also. So I think that interaction and communication is extremely important. As Dr. Laskar said, that many times surgeon will just forget to put it, or so I think every hospital or every team will develop their own niche ideas or on niche ways to sort of communicate things, and I think that is helpful. So Dr. Laskar, let me take you back to the extremity sarcomas more in detail. Why do you prefer post-operative radiotherapy in your institute? Any specific reasons for it as compared to pre-operative?
So yeah, the number one is because we want to do brachytherapy for every patient. And if you're doing preoperative radiation therapy, you're not doing brachy. And our experience and our own results show that with brachytherapy, we have extremely good outcomes. These are all published data. So our outcomes are extremely good. So the most important reason why we don't want to do preoperative is we want to do brachy. And why do we want to do brachy? Because our outcomes are 90% at 10 years or 80% at 10 years. Our complication rate is 6%, whereas IMRT complication is 11%. So we don't want. And if you have a positive margin, you've seen the problems of trying to boost positive margins after pre-operation therapy. And the most important you've seen is the complications, the wound complications. You have 34% wound complications with, and these are, mind you, in patients treated in Canada. And the patients treated in Canada had volumes less than half of the volumes that Dr. Gulia would be doing here.
Sir, does having intraoperative placement of brachytherapy catheters, would it increase your hospital stay? Because in a private setup, the cost of treatment also decides unfortunately a lot of things. So although our volumes are not that high, but I'm sure Dr. Prexi can chip in. But does it actually increase your hospital stay? Because you will not be able to start radiation anyways before 3-4 days till the drain output and the stuff dies down.
So in our hospital, normally we would start our radiation around, it depends on how we have placed our tubes. Normally we would wait for about 2 to 3 days before we start. So third day if we start, or fourth day if we start radiation, so that's 4.5 days more. So that's 4th, 5th, 6th, 7th. So 8th day or the 9th day of surgery, your catheters can come out. And that's the end of treatment. We have finished the entire course of treatment for that patient. So cost-wise, so that I think Ashish can correct me. Normally, you would keep a patient with soft tissue sarcoma for about 5 days or 6 days.
Five or 6 would be for a limb. Yes.
Yeah. So you would 6 days anyway you're keeping. So your additional 2 more days because of the brachy. So, or 3 more days for brachy. But imagine he or she doesn't need to come back to Mumbai or Delhi or any other place. They can go back home. Otherwise, they'll have to go back, come back, radiation therapy planning, stay in that place for 6 weeks, and the associated, things that you have to have. But I don't think you're saving any money by sending them.
Okay.
So Shubham, if you really look at the cost effectiveness of any procedure, it is not just the revenue generated or the expenses done at the time of the index surgery, but if you look at that, patient will have to travel every single day for about 5 weeks, and maybe a lot of high-end facilities, as Dr. Laskar said, are not available in the hometown. So if you look at all that cost, I think brachytherapy is actually cost effective as compared to external beam therapy. And we have very good experience with brachytherapy. And as Dr. Laskar also mentioned, that it's just addition of maybe 3 days more, and it's very comfortable. I'm not sure if any of our patients have really complained that I was staying for 3 days additional and over there. So because they understand that coming every single day to the hospital for next 5 weeks is going to be a bit of problem. So Dr. Laskar, we were speaking about pre-operative and post-operative radiotherapy. You rightly mentioned that we in TMH prefer post-operative because we are really wary about the kind of disease we see, the large volumes we see, a lot of dissection is involved, and the rate of wound complication is pretty high with pre-operative. And also one more point to add, that in O'Sullivan's trial, which they sort of looked at those patients later on in the second part of their study, they started doing free flaps or local flaps for each of the patients. But again, in country like us, it will actually add more cost to the treatment by doing an additional procedure, which again can fail. So I think we are pretty happy with post-operative radiotherapy, and as Dr. Laskar said, that we have a great armamentarium with us, which is brachytherapy, which has really helped us. So, Dr. Laskar, there's a question about whether pre-operative radiotherapy or post-operative therapy, is there any survival difference between the two? So I know you have already showed, but just because somebody asked, I think if you can just quickly elaborate on it.
So in the initial, the SR2 trial, randomized clinical trial, the preoperative radiation therapy showed improvement in survivals, in overall survival improvement. But in the long-term follow-up, there was no difference in the survivals. The survivals were same. And if you look at the other trials, other studies where they looked at the outcomes of pre-op versus post-op, there was no difference in survival. So local control and overall survival, they were the same.
Great. Dr. Laskar, a lot of questions on brachytherapy, and I think one question has been repeated a couple of times, and people are very keen to ask that how Dr. Laskar takes a call pre-operatively, because I know almost 95% of the times when we both discuss a case pre-operatively, we know whether brachytherapy will be feasible for this case or not, and that's why we will never operate any case where we consider pre-operatively brachytherapy feasible and you are not there. So how do you take that call pre-operatively, and how do you decide that this case is suitable for brachytherapy? So in other ways, what are the contraindications for doing brachytherapy?
So yes, so to be able to do brachytherapy, you need to ensure that you would be able to insert the brachytherapy catheters in such a way that you cover the entire clinical target volume. That means the entire area that you would want to treat. So you need to evaluate the tumor bed or the possible tumor bed, look at the critical structures that could be there, and the areas that you're concerned about is the blood vessels and nerves. So we would, number one, see whether, irrespective of any critical structure being around there or not, whether we'll be able to cover the tumor bed adequately or not. So if you have a nice flat area that you would be able to treat or required to treat, that's the easiest. If you have a vessel nearby, you can talk to your surgeons and ask them, how close are you going to come? Will you be able to give me a small muscle flap? And if you're unsure whether you will be completely sitting on the blood vessel or not, you should go to the operating room when they are operating, be there, prepared to do brachytherapy. Many a times you may have to come back because you find that you may not be able to do brachy. But I can tell you, most of the times when you feel that it is borderline, if you're in the operating room, you may be able to figure out ways by which you can do. Nerve is not a real problem, because nerves, even if there's a damage in a little, it's not a major complication. But vessels, large vessels, if you damage them, they can have bleeding and other problems. But fortunately for us, we've never had a complication like that. And many a times they can interpose a small sliver of tissue. So yes, contraindications are neurovascular bundle in the tumor bed, which is written in the books. But for us right now, neurovascular bundle is not a contraindication. We do get our way around it, but generally, yes. Sometimes one would say that periosteal stripping is a contraindication, because if the wires are lying straight on the exposed bone. But there are ways to circumvent that also. So that also for us right now is not a contraindication. So for us, nothing in the contraindication. For the books, yes, these are the standard contraindications. Not able to cover the tumor bed adequately, close to neurovascular bundle, exposed periosteum, or exposed joint. These are contraindications in the books. But when you specialize, when you get better, you know what is going to be harmful and what will not be harmful. So broadly, theoretically speaking, these four are the contraindications.
Thank you, Dr. Laskar. So as Dr. Laskar very nicely elaborated that, all the contraindications which has been postulated in the books, these are relative contraindications, and we have evolved a lot. Dr. Laskar has been doing brachytherapy for 2 decades now. And these 20 years, we have really evolved in doing the kind of cases we have been doing. A lot of people used to have question that if a tumor is around the joint and there's mobility, but we have found our own ways to immobilize the joint for 6 to 7 days, which is absolutely fine. We give nice slabs, maybe anterior and posterior slabs. There are various ways, as Dr. Laskar said, that we cover the neurovascular bundle. Nerves are pretty resistant, and some few patients may get some transient neuropraxia, which is completely recoverable. So I think it's the practice which makes a difference. So I think, except for very huge cavity where you cannot achieve the contour, except for that, I think if you are in good hands, the brachytherapy have given good results. Dr. Laskar, one more question has come now. That what will be, you are a very big proponent of brachytherapy and post-operative therapy. What will be your indications for doing pre-operative radiotherapy? A few specific cases, or what are the special indications for where you will use pre-operative RT?
Yeah, so I would definitely send a patient where our surgical colleagues feel that the surgery is going to be marginal in them, or a borderline resectable tumor. So in them, we would consider for preoperative external beam radiation. So that's possibly the only time we would think of preoperative. When it is borderline resectable, or you feel that if your tumor shrinks a little bit more, your surgery would be easier, or we'll be able to sterilize the surgical margin.
Yeah. So many times, Dr. Laskar has really done wonders by giving preoperative radiotherapy, where we could decrease the morbidity of the surgery, where the vessel was like 180 degrees encased, and we were really not sure whether we will be able to achieve an R0 margin. But by forming a nice capsule or maybe a bit of reduction in the size, we could salvage the vessels and decrease the morbidity. So I think borderline resectable cases are the cases where we use it. So how comfortable you are to give post-operative radiotherapy? And I'm talking about especially in your hands. I'm not talking about other centers, but how comfortable you yourself are in giving post-operative radiotherapy on skin grafted tumor bed?
Yeah, so you have to be careful, but if the graft has been taken up well, and before you start your radiation, you've allowed it to really settle down completely. Giving a post-operative dose of 50 gray in 25 fractions, or even going up to 60 gray, is not really a problem. We, as you know, we not only do external radiation therapy for patients with skin graft, we also do brachytherapy in patients with skin graft. And fortunately, till now, we've never had a single graft, failure because of brachytherapy. So you have to be careful. It's slightly more complicated, but if you are careful enough, you should be able to do. So if you're asking me yes or no, 100% yes.
Any specific precautions or any change in the contouring or anything different you do when you have such delicate grafts there? Yeah.
So see, one thing is there that we cannot compromise on what you need to treat. The clinical target volume, the microscopic extent of disease, you have to include that. But the only thing that you can do is, by some way, if we can reduce the dose to the skin. So if you can reduce the dose to the flap to restrict it to 50 gray or maybe 45 gray, by doing something conformal and all that. So that helps. But I've seen that even if you end up giving 50 gray to the skin full dose, you are not going to have a problem if you have allowed enough time for the skin graft to really settle down before you start. So if you're in a hurry, don't be in a hurry to start radiation. So allow the skin graft to settle down. 50 gray of radiation is not bad.
So average time of waiting before starting radiation for skin graft, I mean, you said we'd wait longer for the skin graft to settle down. It will approximately take 4 weeks for me to say that the skin graft is well taken up.
So in our hospital, unfortunately, because of the popularity of Dr. Puri and Dr. Gulia, our patient load is such that we never can start our radiation before 4 weeks. There are so many of them. My appointments, thanks to them, is 2 months. And it's only in the COVID times that I'm starting radiation stat. So 4 weeks is like privileged if we can start in 4 weeks. Ashish is smiling.
Yeah. So usually with skin grafts, we wait for about 6 weeks minimum.
Yes.
6 weeks.
And we really ensure, and especially with the flaps as well. So the same the same sort of protocol goes with the flaps as well. We might have to delay radiotherapy a bit if we have some ooze coming out from the edges, and we let them settle completely, and then about anywhere between 6 to 8 weeks is a good time to start that.
Just a small caution for people who would be interested in doing radiotherapy with the plastic reconstruction. Many a times you will find that the graft has actually been taken up very well, but you would have in the corners, you may have some scabs sitting. But please don't get carried away, because those scabs will fall off, and then within no time you will find that the whole thing actually just flares up. So allow that scab to settle down. Don't be in a hurry. So 1 month, as I showed you, 1 month and 2 months doesn't really make a huge difference. You should try to start on time, but it doesn't make a difference.
Yeah. So Dr. Laskar, my next question is exactly related to that. It's not in the chat box, but a lot of people ask us that question. That when do you feel, what is the window where you feel that the radiotherapy acts best, and what is your comfort zone? Like, for example, we said about 4 weeks, from 4 weeks to 2 months, 3 months, 4 months. How do you take the call? And when it is like, now it is not given, then it doesn't make any damn difference. So there's a lot of ambiguity on this question, and a lot of people ask this. So I will be thankful if you could just.
So that's the reason I showed that data to you, regarding the interval between surgery and starting radiation therapy. And in this French study, they looked at less than 40 days, 40 to 80 days, and more than 80 days. It didn't make a difference, a huge difference. But if you ask me how soon, I'm okay as soon as the wound heals. And I would assume at least 3 weeks post-surgery to wait, at least 3 weeks. 4 weeks is good to wait. The wound would have healed normally unless there's some, that's the earliest. On the other side, how long I would be okay to give radiation therapy? I would say if it's gone beyond 3 months, I would say, so beyond 90 days, I would say it doesn't really make a difference. If it has to come back, it will come back.
Okay.
So beyond 90 days, I would not. But is it backed up with solid evidence? The answer is no.
Okay. Dr. Laskar, there's a question about the role of radiotherapy in low-grade tumors. A lot of people feel that, and there is some literature which talks about that, when the mitotic activity is low, radiotherapy may not be really effective. But what's your take on the role of radiotherapy in low-grade tumors, and what are the indications? Where do you use it?
So when we say low-grade tumors, in a way, we are talking about desmoid fibromatosis. We are talking about DFSP, dermatofibrosarcoma protuberans, and probably we're talking about other low-grade soft tissue sarcomas. So let's touch upon desmoid fibromatosis. So if anyone looks at the current recommendations, would be not to intervene till surgically or with radiation till the time it is causing some kind of deformity or functional compromise or things like that. So we also follow that. But if you ask me what is the role of radiation in these patients, yes, the data that is available from whatever little data is available, one knows that if you are doing post-op adjuvant radiation therapy, the outcomes in terms of local control is much better much better than what you would achieve with radiation, with surgery alone. So, so the evidence says that you should back it up with post-op adjuvant radiation therapy. One may say that let us wait for a recurrence. The evidence says that waiting for a recurrence to happen actually does not help in improving local controls. So if you're doing surgery, you should back it up with radiation therapy. The worry is about, people talk about malignant high-grade transformation. The answer is there is no evidence to say that radiation therapy actually leads to a high-grade transformation. It would anyway happen if it had to happen. So it doesn't really happen. And the development of second malignancies, it is very low. It is very, very low. It's 5% or 4% in the long run. So, I mean, it's a controversial area, but if you ask me what's your personal call, I would do post-op adjuvant radiation therapy. And when I look at the published evidence, it clearly shows that
Absolutely.
it shows improved outcome. There's no doubt about it.
Because I think surgeons from the beginning, from the old era, have been really underestimating the kind of disease fibromatosis is. Intraoperatively, you are not very comfortable, or you don't even realize how the tentacles which have gone inside the muscles, and that's why we start talking about 5 centimeter margins in fibromatosis and still getting local recurrences. So actually, the disease clearance is not adequate, and most of the time, these lesions are pretty huge, which are very close to neurovascular bundles. So anyways, your margins are compromised. So there is enough data to show that backing up with the radiotherapy really decreases the local recurrences if you are operating them. Dr. Laskar, there are a couple of questions which talks about the role of intraoperative radiotherapy. So what is your view on this technology and the outcomes?
Yeah. So intraop is a good treatment modality, but unfortunately, what happens is number one, you need to have a complete setup. Huge thing, an accelerator which can come into the operating room, or you should be able to take the patient from the operating room to the accelerator. That is number one. You have to have the infrastructure, which is extremely expensive. It is big. Number two is there are various injuries that can happen to structures when you get the radiation cone close to the structure that you want to treat. So that's injury to the vital structures, injury to tissues that can happen. Number three, infections that are associated. And number four is that you cannot get away with intra-op radiation therapy alone. You have to back it up with radiation, because external beam radiation. That's because intra-op, you can give 1 fraction of radiation, or max 2 fractions of radiation, but you have to back it up with remaining. So in all, it's not a very exciting thing for soft tissue sarcomas. It used to be used for retroperitoneal sarcomas, rectum and things like that. Intraop IORT was used. The Japanese used it long back, but now there's hardly any role of intraop.
We have done it for some patients. Vivek and Dr. Preksha are here. They can chip in probably that, we actually arranged the patient to be shifted during surgery with the ventilator, everything through the lift and it was specifically for pelvic sarcomas, because we felt that, the pelvic side wall, we will not be able to give them a good dose. But that is what our experience of IORT. And I have seen those images, where there's this cone in the OT itself, and I'm sure it's expensive. But is there an institute which is doing it very regularly, IORT?
In India, I don't think we have.
Not outside India, so probably sure inside India.
The Japanese were doing, but right now I don't think anyone is doing intraop radiotherapy for sarcomas. There is some people who do it for rectum and things like that, okay. But for sarcomas, no one is doing. So
what about your center in Germany, Heidelberg? Heidelberg in Germany. Yeah, because once I'd gone to see intraoperative radiotherapy in breast, and they had a whole lot of these flat plates, which could be placed in various parts, even in the neck. For the neck they had something with the rectum, and then they had something for the limbs as well.
So I don't know whether they do it. As I said, IORT people are doing, and in India, Zeiss is trying to push IORT a lot. And I think in Mumbai, Raheja Hospital had that is mainly used for breast, like in the breast, resection cavity, they would put in the cone and then deliver radiation. In UK, I know my friend Jayant Vaidya, who used to be here in Mumbai in TMH,
Yes, yes.
is currently a big proponent of Target. And
That's
you would have heard about Target trial for breast. He just came, his results just got published. For breast, people are using, but there are lots of downsides of intra target therapy. Yes.
So it's exactly like that. You have easier ways and better ways, and maybe better outcomes. So why to explore something which may be a bit dangerous, and it's difficult to do technically, and require sort of logistic support. So I think we have much easier ways to handle it. Dr. Laskar, I know we have taken a lot of your time, but I think there are a couple of more questions which I would like you to answer. One is a lot of people talk about that extremity is still okay, but do you see the similar results from brachytherapy in other sites like head and neck and chest wall? What is your experience on that?
So yes, so I literally do for all sides. I do for head and neck. I do for orbit. I do for neck. I do for recurrences in the neck. We do it for axilla. We have done it for urinary bladder. We have done it for prostate. So any site that you say that we can do, and we have done it. It's not that I'm just telling.
And your results are similar in terms of complication rate.
Yes, yes.
And the outcomes.
So yes, although the numbers are much less than what we have done in the extremities, but I don't think we have had complications. The only complication that we have had in brachytherapy is wound dehiscence in a few patients. And, so we have to be careful. In some patients, we have had some excess dose to the skin and there's an ulcer. So that's the only complication we have seen. We don't have bone problems. We don't have fractures. I don't remember fractures. I don't have ocular injuries. I don't have urethral injuries. I don't have bladder bursts. So complication wise, none. And control rates wise, they are more or less the same. Okay. More or less the same, yes. In the chest wall, it is very exciting because the chest wall, the thickness that you need to treat is just optimal with brachytherapy.
Exactly, and you get a nice flat surface, I guess, you can put your wires. And actually, rather than some of the deeper cavities in the thigh, it is much more better to do in the chest because the area of distribution, you get a good surface to put the wires. Dr. Laskar, we all know that the coming year 2021 is pretty exciting for you as well as for Tata Memorial Center. You are the director for the upcoming hydron therapy, where your efforts have really paved the way of getting proton beam therapy, heavy ion therapy in India, which will be available at a very cost effective ways to all the needy patients. So few lines on this facility which is coming up, and specifically with the advent of this therapy and available to everyone, what will be the role of proton therapy for the management of soft tissue sarcomas?
So yes, so it is very exciting, and we are almost there, but we have some more work to be done, and hopefully we should be clinical by May, June, maybe next year. So 2021 May, June, we should be ready. We will have a very big center. We will have 3 gantry rooms. We'll be a large volume proton therapy center. And like Ashish mentioned, we are actually looking at heavy ions in the future. We are already working on it. But first proton. Coming to what patients we are going to use them, definitely a lot of use in sarcomas. I would possibly use them more for the bone sarcomas than in soft tissue. I would still continue doing brachy in soft tissue sarcomas, but for the bone sarcomas, chordomas, chondrosarcomas, it will be extremely useful. Not because it is going to do magic, because biologically it's more or less the same. The dose that we are going to deliver is more or less the same. But the magic part is the toxicity would be much lesser because of conformality. And because it is more conformal, we may be able to escalate doses to higher levels. So maybe in big chordomas and chondrosarcomas, we may escalate to 70 gray, 80 gray also, close to 80 gray if required. So that will obviously improve local controls. Re-radiation, we are going to use a lot of pediatrics and things like that. So it is exciting times for us.
Thank you, sir. Before I hand over to Dr. Parekshi for wrapping up maybe few technical questions or questions which are extremely specific to RT, I would like to request Dr. Laskar for another session with us, because there are a lot of people who and there is a lot of excitement in knowing the role of radiotherapy in bone sarcomas as well. We've got a lot of controversies there, and obviously we will discuss more about protons there as well. So, sir, I would again request you to give us some time. We will fix up the time in maybe maybe
we can have it after some interval, not
depending upon the cancer academic schedule. We will have one more session after a few weeks, which I think Dr. Garg will finalize the time. But I would like to request that we should have one more session on management
sarcoma, basically in particular,
RT in the sarcomas, where we can discuss the upcoming role of radiotherapy even in benign tumors as well. So I think that's going to be pretty exciting session. Over to Dr. Parekshi and Dr. Garg.
Thank you, sir.
Thank you, Dr. Ashish. So I also like to thank Dr. Laskar. Sir, it was a very informative session. And I will also like to take two more questions from the chat box. So one was the role of split course radiotherapy in soft tissue sarcomas. Sir, please, if you like to explain this.
Yeah. So the split course radiotherapy actually comes, it originates from the head and neck groups. A large node with a small primary. That's one of those areas there where they started. But there is not much in soft tissue sarcomas. There is some very recent data that has come, which is published on some 16 patients where people have given a short course of 5 gray into 6 fractions pre-operatively. So that's the kind of dose that people are looking at, but no one is really looking at giving a particular dose of radiation, then you wait for some time and another dose of radiation and then do. So that has not helped, but the most recent data is just a hypofractionated pre-operative radiation therapy. That's the only one that is being done now. Split is not really being done for soft tissue sarcomas.
And another question is, sir, how do you evaluate a plan of brachy at your institute, and what are the dose constraints you follow?
Yeah, so that's a 40-minute answer, but I'll have to take you through the entire process. But we generally do a single plane implant, and we prescribe our dose generally to a point which is 0.5 centimeters, that is 5 millimeters to 7 millimeters from the catheters. And we do a dose point optimization. We don't do a geometric optimization. We do a dose point optimization. That means when I prescribe at 7 millimeters, so I'm treating a slab of about 1.5 centimeters to the prescription dose. I would generally, when I'm looking at the isodose lines, I would tell the physicist to show me 200%, 120%. I would tell them to show me 85%, 100%, and 50%. Now, there is a reason why I asked for these. 50% is to see what dose is actually going to the skin, if it is at all close to the skin. Because the skin and the scar, if you can keep it less than that, you will not have complications. Because we are doing 4 gray per fraction, So if you're doing that, that means you're giving 2 gray per fraction to the scar, and it is very less likely that you'll have a problem. And also reduce the subcutaneous fibrosis. Number 2 is I very critically look at 85 and 100. Now, if the difference between the thickness of 85 and 100 is very little, then I would prefer to choose 100% isodose line for prescription, because by doing that, I'm reducing the chances of having a hyperdose sleeve. And I also put in a 170%. That is because I want to look at what is the hyperdose sleeve, if at all, hyperdose sleeve that we have, which is also taken as twice the reference isodose. So if your reference isodose is 85, which is the standard of Paris system, then twice, that is 160, 170% is the hyperdose sleeve. So that's why I look at that volume also. So if there is an area of hyperdose sleeve, I try to, do an optimization there. That optimization, I either do a graphical optimization, but you have to be extremely careful when you're doing graphical optimization, because the moment you move something graphically, you will see a very nice distribution in that area, but the whole thing in the other area would have changed somewhere else. So you have to change the slider from the global to local, and then do. So you have to be very careful about that. So don't be too excited about graphical. Sometimes you just have to change the dual times. Now, so that's how these are the isodose lines I look at. I also turn the, once I've chosen the reference isodose, I tell my physicist to put a dose cloud on now, and then I rotate the whole thing and see whether I'm covering the entire target volume with my dose cloud or not. Because in one slice, you may feel that you're covering everything, but if you go to another offset slice, you may not be covering the entire target adequately. So when you're looking at a particular isodose, you look at your dose cloud, also rotate it around and see how it is being covered. I hardly ever have to give a dose constraint to the bone or to the rib or to a vessel. At times when my catheter is lying directly on vessel, in conditions like where you're doing a pedicle graft, in them, I just ensure that I just create a nice dip in that area. So that is what we do. But none of the dose constraint measures actually would qualify. If you say that, 40% volume should not get more than 60 gray, it doesn't really happen in brachytherapy that way. It is. So those are more for external RT. It doesn't really apply in brachy because there are small volumes that will get high dose, and so I literally don't. Only thing I do is I reduce doses in certain areas, reduce dose to the skin, reduce dose to the scar, things like that. So how much you load from the skin, those are important things that you should do.
I would like to take this opportunity, Rakshi, I would like to take this opportunity to let all the students know that you are more than happy to apply for observership to our bone and soft tissue DMG, to specifically Dr. Laskar. And I think it will be great experience for you guys to learn these special tricks from Dr. Laskar. And now Dr. Laskar being the Deputy Director of Academics, I'm sure we will be able to accommodate the request very well. Rekshi.
Yeah, a great opportunity, sir. So now I would like to move to the answers of the quiz. Dr. Shubham,
Okay. Great. Yeah, just a minute, Dr. Prikshi. I was still, every radiation lecture improves my vocabulary, and today I've learned a new word, dose cloud. I just heard it 4 times, sir, saying it. So now I know what is, I don't know what dose cloud is, but at least I can, impress upon Dr. Prekshi and other radiation guys that I know something which is called dose cloud.
It's more dangerous than iCloud.
Really? I don't know. I was just trying to jumble up some words. Okay. So if Dr. Geeta can also come in, Dr. Geeta, you would have, and I would ask Dr. Laskar sir to please stay in till we give the answers so that sir can actually help us if we miss on some of those answers. Dr. Geeta, you can also share in the meantime how many we have actually participated. Okay, Dr. Prekshi, over to you now.
Yeah. So the first question is, which of the following is the most radio responsive tumor? earlier I said that there is a difference in radiosensitivity and radioresponsiveness. So I will like to tell you that radiosensitive tumor, it means that the inherent sensitivity of the tumor to radiation, and radioresponsive is how fast or how quickly a tumor regresses after receiving radiation. So a poorly radioresponsive tumor may not be radio resistant. So the radiation oncologist must know about myxoid liposarcoma, but because it is such a radio responsive as well as obviously radio sensitive tumor. So answer is second, myxoid liposarcoma. The second question is, sir has very well explained and the things are very much clear. So for pre-operative RT, the dose is 50 gray. In post-operative settings, in phase 1, we give 50 gray, then shrinking field phase 2. If it is R0 resection, 60 gray. If it is microscopic positive, then 66 gray. And as sir has also mentioned that if there's gross residual disease, then such patients should be given 70 gray. However, I suppose that such patients can also be sent for re-resection. If it is not possible, then in such cases, 70 gray should be given. Then the answer to this question is the dose of LDR boost is 12 to 20 gray. It is a bit higher, that is 15 to 25 gray. So for pre-operative versus post-operative, everything is true. There is less tumor seedling. The thickening of capsule may lead to easy resection. However, in pre-operative settings, the wound complications are higher as compared to post-operative settings. Sir has also explained this part also. So third one is the answer. For desmoid tumors, surgery is the mainstay. But whenever it is an unresectable tumor for head and neck, superficial trunk or extremity side, the doses are to the tune of 50 to 56 gray. Again, the false statement in this question is that electron IORT has lower rate of peripheral neuropathy as compared to HDR. It is opposite to that. HDR has lower rate of peripheral neuropathy as compared to electron IORT. So this 2, 4, 3, 2, 3 is the correct sequence of answers to the quiz.
So Dr. Geeta, great.
I also like to thank Dr. Siddhartha, such a wonderful session, sir. It has always been a pleasure listening to you, your sessions. And Dr. Gulia, to invite him for this session. And Dr. Shubham Garg, last but not the least, he is the main person who has organized such a wonderful
session. What Dr. Gulia has done, Dr. Gulia has also engaged Dr. Laskar for another session for us. And I'm sure Dr. Laskar could not refuse it on air actually. But sir, we'll not burden you and we'll get it after a month. So don't worry. It's not that we are asking, but it was really nice having you. But now, Dr. Geeta, there's great responsibility on your shoulders being the quiz master because Dr. Gulia has already announced the prize. So now we have to keep a note of who's the winner.
So we had about 13 responses, but unfortunately not one of them got your answers right, which is kind of, was it really that tough? But we've got 2 of them who got 4 out of 5 right. And that is Dr. Trishita from PGIML, and the other person is Dr. Ankit from Cancer Institute. So these are the 2 people who got 4 out of 5 right. So I think we'll just give it to them.
That's not a problem. We in the next lecture they can try their luck hard, and so as I promised, we will have one of the radiation oncology students joining us in IMSOS, and which will be supported by me. And again, to excite the students more, Dr. Laskar is the chief radiation oncologist making the program for IMSOS. So I'm sure now you will read more, and I think in his next lecture you will be more prompt and
I'll ensure that they get a prize and you have to give them Ashish.
Yes, that is true. But I'm sure he'll keep the registration free, sir. I'm sure he'll do that.
No, I will support the registration, and again, more because Dr. Laskar will be most probably we have not finalized it, but he will definitely be doing a very specific session only for a radiation oncologist. It may be a workshop or something like that. We have not decided that, which Dr. Laskar will decide in due course of time, but definitely it's going to be good session for all radiation oncologists specifically as well.
While we're at prizes, I think, we should also probably initiate the process of giving away a cash prize of 1,000 at least once in a month. But we will not really say which week it is going to happen. So we'll just give it once. What do you say, Shubham? Once a week in a month.
We're still talking to Rosh. We're still talking to Rosh.
No, we've got one, but it's a very small amount. So it's about 5,000. So I thought, we should keep the interest alive and maybe do it once in a month. And by the time we will book the other guys in.
Okay.
Dr. Ashish can give $1,000 a month.
So that is what we were expecting. He just stopped at the registration, which I'm sure would anyways be free. But that is how Dr. Gulia is. But still, so you know what?
What else you want? I'm asking them to join Dr. Laskar in TMH and Observer. I'm giving them a registration. I mean, I think this is just uncomparable.
Uncomparable, sir. Uncomparable. We can't argue with that. But
we will make it more interesting in the future. But we used to have this. I was just discussing this with one of my colleagues with whom we used to do this C4, which was challenging case capsules in cancer.
Yeah.
So what we will do is we'll get the students to present and have a panel of jurists, like eminent people like you, who can judge, and probably we need to bring out the multidisciplinary flavor. And probably introduce the trainees into it earlier than later. And that definitely deserves a prize. So I think we'll work on that and just pick up one system probably once in 2 months. And
Agreed. We should do that. So it is basically just to create interest, that, different formats, allowing us to keep the interest alive and transmitting the knowledge that, we can get from people like Dr. Laskar and Dr. Gulia. So thank you, sir. My takeaways from this talk was your last summary slide, which actually summarized the whole answer for me in the short question and all the references that you had. So any students who want to create an answer should look into the archives of YouTube Academy and get their answer made a short note, which I'm sure they can write again. Second was, allowing me to give radiation to skin grafts, because we have a lot of fight. Me and Vivek, we work together that, we are fighting to get a skin graft, and a plastic surgeon says, no, that I want to do free flap. So now I'll make sure that we reduce our cost further and get a skin graft, and obviously dose cloud at the last. I'll read about it, dose cloud, sir. Thank you so much. And this is going to be our next class, tumor lysis syndrome, a case-based discussion. We are expecting Dr. Poorna Kurkure, madam, the head of NH Collegium of Oncology. Madam is a previous professor at Tata Memorial, and she's a very eminent pediatric oncologist. And we hope that will be really a case-based discussion. It will not be a didactic lecture, but we'll try to curate 3-4 cases to discuss what are different things. And I think it should interest everybody, surgeons the least, but I'm sure we'll have a good audience. Okay. Thank you, everybody. Thank you, Dr. Laskar, sir. Thank you, Dr. Gulia, sir. Good night.
So, sir, thank you very much for your time, and thanks for agreeing to give the next talk as well.
Thank you, sir. Thank you.
That's a good one, Ashish.
Okay. Good night, everybody. Good night.
Good night.